continue.
Yeah. Okay, great. I'm going to pick up where Ajay left off and talk about some of the newer data in heart failure and sort of how we manage it sort of in the modern era. Can you guys hear me? Okay. So some of this stuff has been covered in the previous sessions, excellently so I'll skip through it a little bit in the beginning. But just briefly about SGLT2 inhibitors, which is the first class that we're going to talk about. Interestingly enough, the main sort of active compound, or similar to the active compound, was found in the apple tree in the 1800s. Later, we found that it actually inhibited glucose reabsorption, as was described previously. And later, synthetic derivatives were found to reduce A1C without causing hypoglycemia, as previously described. So the cardiovascular outcomes trials were mentioned, and the main one with, the first one with SGLT2 inhibitors was the EMPA-REG trial. So I'll kind of skip through the gist of it since it's been covered, but the primary outcome was composite of cardiovascular death, myocardial infarction, and non-fatal stroke. 3-year follow-up patients. These are high-risk patients with prior high cardiovascular risk. And you see a marked improvement in the primary outcome. You can't read it, but take my word for it. This figure shows death from any cause. So you see a nice separation of the curves. So there's actual mortality benefit here in this cohort of patients. Next, heart failure hospitalization. So this is where we first started picking up a signal that there is a marked heart failure benefit to this class of medication, which was not realized or expected prior to this cardiovascular outcome trial. That was empagliflozin. Dapagliflozin, this was in 2019 in New England Journal. Similarly, we had to perform a CVOT for this. These are a low-risk population. This is not established cardiovascular disease, but patients who are simply at risk for it. Similar primary outcome, a bit of a larger trial. So again, we see a marked benefit in the overall composite outcome of death and heart failure hospitalization. However, in this trial, death was not significantly improved with dapagliflozin. And this is not thought to be to the detriment of the medication, but probably more related to the risk profile of the patients who were entered into that study. So being a low-risk cohort of patients, we might expect less benefit in terms of a heart outcome like mortality. We do think of the benefits of these to be generally a class effect. Mechanisms of action, again, previously covered nicely, so I'll kind of skip over this data. One thing I want to mention is because of the reabsorption, what we end up getting is changes in the glomerulus with efferent vasodilation and afferent vasoconstriction. And that reduces hyperfiltration in the kidneys, which is thought to be one of the main mechanisms of long-term renal failure in the diabetic population. There are a number of extraglomerular benefits thought may be independent even of both natriuresis or glycuresis. And these are not well established, but are a very active area of research. Cellular and metabolic pathways are studied for this mechanism. Next, I want to take you to dapagliflozin in patients with heart failure and reduced ejection fraction. This is the first study specifically looking at a heart failure cohort and this class of medication. So what we looked at first was patients who with a reduced ejection fraction who were symptomatic with heart failure. They had to have a elevated natriuretic peptide level at baseline and kind of reasonable exclusion criteria. They couldn't have significant renal failure, blood pressure had to be able to tolerate, and these were not studied in type 1 diabetics. So importantly, this trial, and as are most cardiovascular trials, predominantly involve a male and Caucasian population, so results have to be extrapolated with a grain of salt. But we see that it's a relatively sick cohort of patients, an elevated natriuretic peptide level, NT-proBNP of 1450, 2/3 class 2 and 1/3 class 3 heart failure. And interestingly, only 40% of the patients in this trial had diabetes. Patients were, because of the timeline of when this trial enrolled, only about 10% of patients were on sacubitril/valsartan during it. So It's not truly a modernized cohort in terms of heart failure therapy. However, the outcome was kind of standard in heart failure trials, which is cardiovascular death and worsening heart failure. And how do you define worsening heart failure? Well, either you're hospitalized for heart failure or you require IV diuretics in an emergency room or an urgent care center. Key secondary outcomes, breakdowns of those primary composite. An important one is the KCCQ, which you may not be familiar with, but is the Kansas City Cardiomyopathy Questionnaire. And this is a patient-centric outcome. So it's patient-reported symptoms and quality of life, which is in sort of the cardiology and heart failure world becoming more and more important in trials as an important outcome, because something like time to first heart failure hospitalization, which is a traditional endpoint in heart failure trials, may not be as important to patients as day-to-day quality of life or number of hospitalizations or other things which are more patient-centric. So KCCQ is important in that we can tell people if there's a change in this endpoint that we should expect that they would feel better day-to-day. And 5 points is what's considered a meaningful benefit in this metric. Worsening renal function is another important secondary endpoint. Are we causing worsening renal function? Are we preventing it? And that's defined as a decrease in eGFR of more than 50%, or development of ESRD. And safety outcomes were studied as well, of course. So reminding, the primary outcome of cardiovascular death or worsening heart failure, wow, a marked benefit. Hazard ratio of 0.74, highly significant, driven predominantly by heart failure hospitalization. Cardiovascular death also significant in this cohort, however, with 18% reduction. So no safety signal for harm. In fact, the renal serious events occurred more often in the placebo arm than in the dapagliflozin arm. There's no major heterogeneity across subgroups, so we think kind of broadly it applies to everyone as a benefit. And this is where we first saw the signal that this class of medication may be beneficial in patients who do not have diabetes. So as a reminder, 40% were enrolled with diabetes, 60% without. And you see from the subgroup analysis that essentially the benefit appears similar with or without diabetes. Again, the KCCQ, that patient-centric endpoint of quality of life. So we're looking at who had small, moderate, and large improvements, or who got worse on medication. So from the left, this shows people who are worse. Let's use a pointer here. Patients who got worse, so placebo is blue, dapagliflozin is red, so a little bit less fewer patients got worse on the active drug. And then small, moderate, and large improvements in quality of life. So each of these is significant independently. So you can see that we should expect that our patients starting this therapy would have improvement. And further observational studies have shown the improvement occurs early and is sustained. So we can expect that within a month of onset of medication, patients can expect quality of life improvement in functional status. Emperor reduced, so this is the empagliflozin correlate of the dapagliflozin data. Again, studied in a heart failure specific population, reduced ejection fraction. Pretty similar endpoints. However, this is a sicker cohort of patients. We required higher natriuretic peptide levels or a prior heart failure hospitalization. Again, very similar breakdown of patient demographics, however, a higher median NT-proBNP level, again, about half with diabetes. And in this trial, being it a little later, we see about 20% of patients, sorry, you can't read that, but 20% of patients were on sacubitril valsartan compared to 10% in the dapagliflozin arm. So a little bit more modern therapy as a background. Similar outcome, this time heart failure hospitalization excluding urgent care visits for IV diuretics, and similar secondary endpoints. So again, primary outcome, composite cardiovascular death and first-time heart failure hospitalization. Another marked win for empagliflozin compared to placebo, with a 25% improvement. Total heart failure hospitalization, another patient-centric endpoint. Patients don't care whether they're hospitalized once in 6 months or 12 months, but they want to know how many times. And a big win here, 30% improvement in total heart failure hospitalizations on empagliflozin. Pre-specified analyses, Kansas City Cardiomyopathy Questionnaire showed improvement. Interestingly, what we see here is an important signal, which is relevant to anyone who may prescribe these medications. We see an EGFR dip, as it's described. So basically, when you first put on an SGLT2 inhibitor, we often see a decline, a modest decline in the renal function of a patient. But you'll see that over time, this marker where the curves cross, red being active drug, black being placebo, is at about a year, excuse me. So before a year, you might have a little bit worsening renal function, but in the long term, there's renal protection with this class of medication. So, and this is shown in further studies, which I won't describe, which are specifically looking at renal cohort of patients, looking at long-term renal function. And we must know that when we start the medication, we can expect a modest decline in EGFR, and that should not prevent us from continuing the medication because we know in the long term it's renal protective. So this is just comparing dapagliflozin and empagliflozin. And I just point out that cardiovascular death was significant in dapagliflozin, but not in empagliflozin. But again, we don't think this is an indictment of the drug, but simply because the cohort of patients was sicker in the EMPEROR-reduced trial compared to DAPA-HF, so it's harder to achieve that benefit of cardiovascular death. So now we've inserted DAPA-HF and EMPEROR-reduced into our timeline of heart failure drugs. What about SGLT2 inhibitors in preserved ejection fraction? So Ajay nicely summarized sacubitril valsartan in this population. So this is the EMPEROR preserved trial, which was published in New England Journal in 2021. So in this one, you had to have an EF over 40, again, symptomatic heart failure, modestly elevated natriuretic peptide level, though not at the degree of those with reduced ejection fraction. And in this one, which is nice to see, we have a much more balanced distribution amongst female and male distribution. And this is what we see in our heart failure preserved ejection population, that it's largely equal, if not female predominant. Again, a Caucasian primary trial with low African-American enrollment, which is not exactly applicable to our cohort of patients we treat here in the United States. Mostly class 2 heart failure. And again, about half with diabetes. And you see the breakdown of ejection fraction. So the median ejection fraction is 54. About 1/3 are less than 50. About 1/3 between 50 and 60, and about 1/3 more than 60. So a nice balanced distribution above 40%. Primary outcomes, similar to previous trials, cardiovascular death and first heart failure hospitalization. Key secondary outcomes, again, renal function and total heart failure. So in our primary outcome, cardiovascular death and heart failure hospitalization, again, a good win in a cohort of patients who really haven't had a positive trial in decades. So you'll see a 20-ish% improvement, primarily driven by heart failure hospitalization, time to first heart failure hospitalization. Cardiovascular death was non-significant in this cohort of patients, which is not to be unexpected, given that HFpEF is a pretty heterogeneous batch of patients with different etiologies, and so it's hard to achieve a benefit given that it's kind of a mixed bag in what we're treating. Importantly, there's a high rate of drug discontinuation, and that's more attributable to the comorbidities of the patient class than the medication, because about 25% of patients discontinued placebo in this trial as well. Here you see a forest plot, subgroup analysis. This is the top line here of these three is EF less than 50, the middle one is 50 to 60, and the third one is 60 or more. So you'll see as the EF decreases, the benefit of the drug, so to the left is active drug, is shown more markedly. So this is where we first saw that there may not be as much benefit as the EF increases, similarly to what we saw in sacubitril/valsartan. And to us, we interpret this as 50 and above is not a normal EF. A normal EF might be 60 and above, and 50 to 60 is some mixed phenotype features of reduced and preserved ejection fraction. And so as the EF reduces more, we start to see more benefit from heart failure therapies. This is comparing SGLT2 inhibitors and angiotensin-neprilysin inhibitors in a HFpEF population. Red being SGLT2 inhibitors, blue being angiotensin-neprilysin inhibitors. So if we look at this top left box, primary endpoint, you see that red is consistently lower than sacubitril/valsartan. In time to first heart failure hospitalization, and even more marked benefit. Cardiovascular death, really no different between the two. And total heart failure hospitalizations, again, improved in the red, which is SGLT2 inhibitors. And this is broken down by EF. So this is EF greater than 63, between 53 and 63, and less than 53. So you'll see the benefit in heart failure hospitalizations really, again, extends more to the lower ejection fraction. And this is the newest study, which was just presented last week, or last month, I should say, at the European Society of Cardiology. Dapagliflozin in heart failure with mildly reduced or preserved ejection fraction. So this is important because it piggybacks on the empagliflozin data, but there's a few important additions to this trial. So in this trial, we include patients whose ejection fractions have improved. So those who were low before and now are above 40, the so-called heart failure with improved ejection fraction. We can take patients who are both inpatient and outpatient in this study, so it incorporates both. And it's a really big trial, the largest of the heart failure trials, so it's a really sort of powerful endpoint. Again, about 45% female, mostly white, a little bit more Asian, and low enrollment of black, self-identified black patients. Again, about half diabetes, median BNP about 1,000. Outcomes, so cardiovascular death and worsening heart failure hospitalization, which includes unplanned hospitalization or an urgent visit to a primary care, an emergency room, an urgent care provider for specifically the diagnosis of heart failure. Secondary endpoints are hierarchical. They test a number of events and they do them in a hierarchical fashion. So again, primary endpoint, worsening heart failure, cardiovascular death with dapagliflozin in a preserved ejection fraction population. Another solid win for dapagliflozin or SGLT2 inhibitors, 18% improvement in this important endpoint. Worsening heart failure event also, again, positive. Death, again, also neutral in this population. Subgroup analysis, interestingly, if we look at, in this trial, dapagliflozin, we don't see the same heterogeneity by ejection fraction breakdown. So the bottom line here is greater than 60%, the middle one is 50 to 60, and the top one is less than 50. So all cohorts of ejection fraction showed similar benefit with dapagliflozin in preserved ejection fraction. So that's an important difference, although I think one that needs to be borne out more. I'm going to talk about a few of the other benefits of this class of medication other than just heart failure or cardiovascular death. Arrhythmias. So this is looking at observational data looking at serious ventricular arrhythmias or resuscitated sudden cardiac death, a benefit for dapagliflozin from the DAPA-HF cohort. What about diuretic potency in acute decompensated heart failure? So this trial looked at 59 patients admitted who had diabetes and heart failure. You see increased urine output in the inpatient setting by adding an SGLT2 inhibitor with no signal for worsening renal function. How about hyperkalemia? EMPEROR pooled, this is basically the combined cohort of patients from the preserved and the reduced EF with empagliflozin. We actually see a reduced incidence of hyperkalemia with SGLT2 inhibitors. This is important because, as mentioned previously, some of the other medications we use in this cohort of patients, mineralocorticoid receptor antagonists, RAS inhibitors, all increase the risk of hyperkalemia, and we can mitigate that with the addition of SGLT2 inhibitors. So much so that in my practice, I routinely start an MRA and SGLT2 inhibitor at the same time to try to reduce the risk of hyperkalemia. No signal for hypokalemia, importantly. How about in anthracycline, patients who've received anthracyclines who have chemotherapy-related cardiomyopathy? This is just retrospective data, so take it with a grain of salt. It's going to be studied prospectively. But there is, in patients who were on SGLT2 inhibitors, there was less reduction in ejection fraction compared to those who were not on the class of medication. What about in acute heart failure? So admitted acute heart failure patients. This is a larger study, 500 plus patients with acute heart failure with any ejection fraction who were randomized early to empagliflozin or placebo in early part of their hospitalization, usually a median by 3 days, and treated continuously for 90 days. This is a clinical benefit trial with the win ratio, so I won't go into the semantics of it, but if you go into the breakdown of the data, there's benefit to a number of heart failure specific endpoints in this cohort. So we can use it safely and in patients without risk of long-term sustained renal dysfunction, hypotension, hypo or hyperkalemia. So I'll skip through this. This is a little redundant data about diuretic effect. So analysis of worsening renal function. This is really interesting. This is looking at the DAPA-HF cohort. So if you look at who started dapagliflozin at the SGLT2 inhibitor, at day 14, 1/3 of patients had no change in eGFR. 1/3 had a greater than 10% reduction in eGFR, and 1/3 had more than a 10% reduction in eGFR. However, the 2%, the eGFR decline greater than 30% occurred in 2% of patients compared to placebo. So not a huge decline in renal function is not expected, but a modest decline may be expected. But the primary clinical endpoint in the DAPA-HF trial, which again was heart failure or worsening heart failure or cardiovascular death, occurred less often if you had worsening renal function. That's what this graph shows here. So the worse your kidneys got, or the more eGFR decline you had early, the better the cardiovascular benefit early. So we, again, need to push through early declines in eGFR and continue the therapy with the expectation that 10 or 20% EGR decline may still be associated with a more marked cardiovascular benefit and a more marked long-term renal protection benefit. I'm going to just skip through a couple or talk briefly about a couple of the more novel heart failure therapies that have come out. These are not used as often, so and probably used more to us heart failure specialists than a kind of a general practicing audience. Vericiguat is a guanylyl cyclase stimulator. Victoria studied this in patients with HFrEF, who is a very high-risk cohort, recent heart failure hospitalization or IV diuretic need. And it was a positive trial for a primary outcome of the usual CV death and heart failure hospitalization. However, it was considered pretty underwhelming overall. I mean, there was a 10% absolute risk reduction in a heart failure benefit. Interestingly, the subgroup analysis showed that the sickest of patients, those with the highest quartile of NT-proBNP, had the least benefit. So this is something maybe you do in a relatively sick but not too sick population. Its role is still to be established. Omecamtiv mecarbil is an interesting compound, which is a myosin activator, studied in GALACTIC-HF in EF less than 35. Again, positive for a primary endpoint, although modestly so, driven by a small reduction in heart failure hospitalization. Subgroup, interestingly about this one is it doesn't lower blood pressure, so subgroup suggests that the sickest batch of patients, those with the lowest EF, the lowest blood pressure, actually had more benefit. So maybe this is something that in our more advanced patients we will use in the future. And importantly, this compound did improve quality of life with the KCCQ. In the last few slides, I want to talk about non-pharmacological advancements. So you may all be familiar with LVADs, heart pumps, which have 25, 30-year history now of implantation. And the technology's evolved. We're on sort of the fourth, maybe fifth generation of LVAD at this point, which is really there's only one model available of the most modern LVAD, which is the HeartMate 3, a centrifugal flow pump with that magnetically levitated to reduce friction. And of course, as you may have followed the story of LVADs over time, they can help some people, but have scary downsides that a lot of people are sort of reticent to prescribe them. This nice study I found on a random website basically takes various LVAD studies and puts them on one graph, so you can look at survival out to 2 years, which is the end of the curve. So the bottom line is medical therapy. These are the sickest of the sick heart failure patients. This is from Rematch 2001 trial comparing an early generation LVAD to medical therapy. 15% of people are alive after 2 years in this cohort. Earlier generation LVADs, you see an improvement, 30, 40%. Over time, we go up. The top line here is heart transplant, kind of considered the gold standard for long-term survival in a sick heart failure population. We see an 82% 2-year survival. Late generation LVADs, HeartMate 3, this is from 2019, the momentum data, a 79% 2-year survival. So overall survival comparable to heart transplant at this time. This is 5-year data that was just published last week. Now at 5 years, we know compared to HeartMate 2, a pretty good generation, a mid-generation pump, yellow line being HeartMate 2, blue line being HeartMate 3. HeartMate 2 at 5 years, 43% survival. HeartMate 3 at 5 years, 58% survival. So an additional 15% survival. But that's not just survival, that's getting patients to other treatment. That's explant of pump, that's getting them to a transplant. Importantly, looking at a feared complication of LVAD, the pump stopping, having a major stroke. In a HeartMate 2, in the momentum data, at 5 years, only 30% of patients in the HeartMate 2 cohort didn't have either a pump thrombosis or a stroke. In HeartMate 3, that number goes all the way up to 54%. So this is not mortality, but these are very important endpoints. No one wants a stroke, obviously, or to have to go back to the operating room for a pump explant or exchange. So really, the new generation LVADs are a whole different ballgame and really open the door to a lot more patients who are feared complications. Not only that, they're simpler to manage. The sort of dependence on accurate warfarin dosing, INR management is less important. It's easier for patients who are maybe not the best candidates in terms of medication management. We have a little bit more safety margin with the new pumps. And in the last slide or two, I just want to talk a little bit about when to refer to an advanced heart failure specialist. Before I mention that, the great thing about these new drugs that we touched on today, Ajay and myself, is they're simple, they're easy, in that they don't have a lot of harm associated with them. It doesn't take a lot of nuance or a lot of carefully navigating landmines to get a patient on the drug. You get them on, you watch the kidney function, you watch the potassium, and you can expect benefit over time. That extends their use to primary providers, nephrologists, endocrinologists, kind of a whole gamut of patients, providers who treat heart failure patients who are not heart failure specialists. However, there are times in which heart failure specialists may be added benefit. And there's this kind of cute algorithm that the Heart Failure Society of America published, which is okay. I think it's a little, I don't know. It makes it seem I don't like the I need help as much. That's what it's called, because it makes it seem like people can't do it on their own. But basically, that's how they make the lighter. So these are things that might make you think about sending your sick heart failure patient to a heart failure specialist where we can intervene early and get them on a path to success. So someone who's on IV inotropes, a class 3B or class 4 heart failure patient, someone who has end organ dysfunction or failure, renal failure, liver failure related to heart failure, a low EF, less than 35, someone who's had defibrillator shocks, who's been hospitalized more than one time for heart failure, who has edema despite going up on the loop diuretic dose, who has low blood pressure and a high heart rate at baseline and you're afraid about getting them on meds, who has to de-escalate meds because of dizziness, hypotension, lightheadedness, they're not tolerating meds they've been on for years. These are signs that someone is sliding in the heart failure realm, and maybe something needs to be done before more damage is done and to extend the option of different treatments to them. And then lastly, for our program, happy to take any questions, comments, referrals at any time. Jay and my contact information, and I'll just stop here and take any questions.